Hi. Sorry, my computer is now. Right. හරි. එතන ඉතුරු ටිකත් හම්බුනා නිසා මම ඔක්කොම මම දැම්මා රුමටොලොජි එක හිමටොලොජි එකක් දැම්මා. ඒතර ඒක සන්දාංගහාරවාද කරලා ඉන්ෆෙක්ෂන් කරමු බදාදාට. එතකොට වැඩි ඉවරයි.
හරි සර්. ඉන්ෆෙක්ෂන්ස් මම හිතන්නේ දැන් නැද්ද කොහොමද?
නෑ ඒකේ පොඩ්ඩයි තියම ඒක දාන්නම්. ඒක අර දෙක කරලා ඉන්නකෝ ඉන්ෆෙක්ෂස් ටොක්සිකොලොජි මේ බදාදාට කරලා.
හරි සර්.
Hi. Okay, පටන් ගමු අපි එහෙනම්.
පටන් පුළුවන් සර්.
Right. Okay. So now what we are going to do today and tomorrow is just go through clinical neurology, and obviously I've taught this to you. Almost 100% of what we are going to just revise today and tomorrow I have taught during your clinical appointments. So it's just going to be a very quick revision, and also some of these concepts obviously will be useful for your short cases as well. So it's sort of killing two birds with one stone. Product as a quick revision. Of course, I'm not going to spend a lot of time describing what I've already done during your appointments, but we'll just go through this very quickly so that you have a nice revision before the exam on clinical neurology. And of course, most of your neurology MCQs will be based on clinical neurology. Appear ithuru tika tamai kare stroke, headache, cerebrovascular disease, etakota CNS infections, e wage dewal tika. Right. Okay. So these two sessions are structured in this outline. So today we are going to talk about higher cerebral function and cranial nerve disorders, and then we'll move on to the rest tomorrow. Right. Now, one of the important things about higher cerebral function is that people recognize over a long period of time that there is a defined structure to the brain, right? So there is a defined structure, there are lobes in the brain, and these lobes have very specific functions, right? Now, however, this overview or this viewpoint might change because things are changing a lot in neuroscience, but at the moment, for a clinical approach, we are able to identify definite anatomical lobes and also specific functions of these anatomical lobes. So for MCQs, you ask, okay, if there's a frontal lobe problem, what will happen? If there's a temporal lobe problem, what will happen? Right. So the first question is asking you, what of the following features are associated with frontal lobe dysfunction? So what are the problems that you would get if there is a frontal lobe dysfunction? Right. Frontal lobe dysfunction. Now for this, let's talk about what you would get in a frontal lobe syndrome. Now this is a famous story. I'm sure some of you might already have heard this, right? This is a railway worker who had a railway spoke or something stuck through his frontal lobe, right? And this is the sort of history of how people started thinking about frontal lobe function, right? I think this skull is somewhere in a museum in the US still. Hari. Now, so this guy didn't die. So he exhibited certain important characteristics, right? And this is how we understand what a frontal lobe syndrome looks like. Now, when the frontal lobe is disordered, you will get motor and language disorders. That is the primary function of the frontal lobe. So you will get hemiparesis and also emergence of certain primitive reflexes, which you are used to talking about in pediatrics, right? And also there will be language disorders, more specifically expressive dysphasia, because Broca's area is situated in the frontal lobe. So the common manifestations are motor syndromes and language disorders. But remember, these patients also get a lot of behavioral disorders, disinhibition, behavioral disorders, and problems with concentration and attention, right? So these are some of the other features that you would get. Okay, right. So let's go through this MCQ now. Right. So what are the following are associated with frontal lobe dysfunction? Urinary incontinence is true. Okay, there is a part of the frontal lobe, this is the posterior aspect, which can cause urinary incontinence when that is damaged. Right. I've already told you that the motor cortex is important, the frontal lobe is important in motor function. And when there is a frontal lobe disorder, you get hemiparesis and also emergence of primitive reflexes, right? And also expressive dysphasia because Broca's area is predominantly situated in the frontal lobe, right? Homonymous hemianopia is not associated with a frontal lobe problem, and that is mostly associated with either a occipital lobe or temporoparietal lobe dysfunction, and I'll explain the reason in a minute. So take a varadi, homonymous hemianopia. And proprioception again is in the parietal lobe because the predominant sensory area is in the parietal lobe. So you won't get any proprioception problems. Hari. I think I had a video of a primitive reflex. Okay. Right. Okay. That's fine. So make up a kara, right? So that is very clear. We have discussed this MCQ, right? Hari. So frontal lobe syndromes are characterized by these problems, right? So it's mainly a motor and language disorder that you get, but of course you can have personality changes like disinhibition, hypersexuality, mutu manifestations, and also incontinence. Hi. Okay. Right. Now the next lobe we talk about is the parietal lobe. So MCQ number 2 is a parietal lobe question. Now, parietal lobe syndromes, the classical features of a parietal lobe problem are sensory. Because remember, the parietal lobe is the main sensory area, right? That is where the sensory is managed. Your parietal lobe is where all your sensory system is managed, right? So that is very important to think about it. You will also get in parietal lobe syndromes homonymous hemianopia or more often quadrantanopia, right? And this is because a large bulk of your optic radiation fibers travel through the parietal lobe, and I will show you a picture in a minute, right? So you get large bundle of your fibers of the optic radiation travel through the parietal lobe, right? So you will get homonymous quadrantanopia most of the time, but I will show you a picture, right? Now, there are also certain unusual manifestations of parietal lobe syndromes, right? And that depends on whether you get a problem in the dominant parietal lobe or the non-dominant parietal lobe, right? So that is important to think about, right? Now, when there is a problem in the dominant parietal lobe, right, in the dominant parietal lobe, they get apraxia, apraxia, right, apraxia. So apraxia is they are unable to carry out instructions based on a verbal command, right? Now let's say you ask them, can you show me how you comb your hair, right? So you're giving them a instruction, you're telling them to do something, right? But they are unable to follow that, right? They are unable to follow that. Another common example is you ask them to blow out a candle, just show how you do that thing. So that is called an apraxia, and that is a feature of a dominant parietal lobe problem, right? And there is another collection of features which is called Gerstmann syndrome, again where you get in a dominant parietal lobe problem, right? And this has 4 features, right? Dyscalculia or acalculia, right? They are confusion. Vammata dakunuwata maru, right? Left-right confusion, right? Finger agnosia, again, they can't point to their fingers and make even very amutu. And also dysgraphia, right? Dysgraphia, they can't draw, right? So this is called Gerstmann syndrome, and this is again a parietal lobe syndrome, right? So these are features of a dominant parietal lobe syndrome, right? Okay. Now, Nipun is going to the question that I was just about to explain there, when there is a non-dominant parietal lobe syndrome, you get constructional apraxia. So constructional apraxia is essentially a slightly different thing from other apraxia. So apraxia is that what you're trying to do is you're trying to tell the person to act out a motor task, right? Constructional apraxia is a bit different, where you ask them to draw 5 pointers. It's a bit of a learned thing as well, right? So 5 pointers, and they know what it is, right? So they're supposed to sort of draw it out of memory or evaki. So it's slightly different, right? Slightly different function, slightly different brain area that you would need for these functions, right? So that is, so you get constructional apraxia in a non-dominant hemispherical lesion. And in a non-dominant hemispherical lesion, they get spatial neglect or hemispatial neglect, right? So one side of space does not exist for these people, right? With non-dominant parietal lobe lesions, right? So this is called hemispatial neglect, and that is a feature of a non-dominant hemispherical lesion, right? So these are your parietal lobe syndromes, right? So parietal lobe syndromes, you have dominant hemispherical lesions and a certain list of features, and a non-dominant hemispheric in a set of features. Okay. Okay, so right. So this question number 2 then is focusing on features of a lesion of the monoparietal. Dominant parietal lobe. Dominant parietal lobe. අපි දන්න ටික ඉස්සෙල්ලා මේව කරමු. So disinhibition is a feature of a frontal lobe syndrome. That's why I told these people act very weirdly. They have hypersexuality. ඒක අමුතු දේවල් තියෙනවා. පාරමැද දුංගලෝකට දුවනවා, that sort of thing, right? Disinhibition. Hemispatial neglect is a feature of a non-dominant hemispherical lesion. So that is wrong. Non-dominant. Non-dominant part of the space does not exist for these people, right? Then constructional apraxia is again a feature of non-dominant hemisphere, right? Acalculia is part of that Gerstmann syndrome, which is a dominant hemispherical lesion, right? Okay. Now I think I had a picture of, okay, but right. And now I told you that in a parietal lobe syndrome, you get this visual field defect, right? And this is because a large part of the optic radiation travels through the parietal lobe, right? So actually there are 2 parts of the optic radiation, right? One part travels through the parietal lobe, and another part travels to the temporal lobe, right? Important thing to remember is the part that travels through the parietal lobe carries light from the lower part of the visual field, right? So udin yaneka, parietal lobe එකෙන් yaneka, that carries light from the lower part of the visual field, right? පල්ලෙහා හරිය, right? Whereas the fibers that travel through the temporal lobe යටින් තියෙන එක carry light from the upper parts of the visual field, right? So මාරු වෙලා යන්නේ, right? Parietal lobe එකෙන් යන්නේ the light coming from the lower part of the visual field, whereas in the temporal lobe it is light coming from the upper part of the visual field. So it's reversed, as are most things confusingly in neurology, they are reversed, right? So when the parietal lobe goes dominant hemisphere, non-dominant hemisphere, ඕන ලබ්බක් ගියොත් එහෙම you get lower quadrantanopia. So it will be the lower part of the visual field that is affected, right? Because of the disruption of the optic radiation fibers. Okay. Right. Tisura, you have a question?
Yes, sir. Sir, is this stereognosis part of this apraxia group?
Stereognosis is a sensory function.
Right. Okay.
Right. So that is a general sensory function. Yes. So Hiran, again, something that I was about to mention is that you can get a certain form of dysphasia because in a dominant parietal lobe function problem, because Wernicke's area is a bit of a complicated thing. It lies somewhere between the frontal and the parietal. So some people, you can get in a pure parietal lobe lesion, you get this receptive dysphasia as well. But it's a bit of a complicated area because part of it is it's sort of in between the frontal parietal your Wernicke's area, right? And part of it is the temporal also. So it's a bit difficult. So it's a mada තියෙන එකක් ඒක. Frontotemporal parietal හැමතැනම වගේ Wernicke's area එක තියෙනවා, right? So you can get receptive dysphasia mostly in temporal, but parietal එකෙත් සමහරලාට එන්න පුළුවන්. Yeah. Okay. Yes. There is another question.
Sir, අර fibers එනකොට lower part එකේ light නේ යන්නේ. ඒ කියන්නේ fibers කොහෙද cross වෙන්නේ? යටින් යන fibers ටික එහෙම යනවා, උඩින් යන fibers ටික එහෙම.
ඔව්, ඒ fibers cross වෙන්නේ නැහැ. නමුත් ඒ fibers වලට project වෙන්නේ ඒ වගේ project වෙන්නේ උඩ යට visual field එකේ.
Okay.
Okay, good. So that's fine. Right. Okay, any other questions about those two MCQs?
Sir, hemispatial neglect එක ඒකේ සර් අපි කියනවා නේද අර මේ ඔරලෝසුවක් හැඳලා ඒකේ යාලා අඳින්නේ ඒ කියන්නේ අර එකේ ඉඳන් 6 වෙනකන් එක පැත්තක ඉඳන් අනිත් පැත්ත අදින්නේද නැත්නම් එකේ ඉඳන්
එකේ ඉඳන් 12 වෙනකන් එක පැත්තක අඳිනවා. Because that, so they can write the numbers, but part of the space does not exist. So if you ask them to draw it, they'll draw 1 to 12 on the same side, right?
Okay.
Hi. Okay, good. Hi. Now a very similar question for the temporal lobe. Right, very similar question for the temporal lobe. Now the temporal lobe is an important thing. As I told you, මේ Broca's area කියන්නේ මහා වාත එකක්, හරිද? ඕක මේ බලන්න මේ Broca's area මේ Wernicke's area, right? So Wernicke's area is a bit of a problem. It is sort of situated in a very difficult place, right? So that temporal, parietal ඔය තැන් දෙකේම තියෙන්න පුළුවන්, right? So what you get in a dominant temporal lobe syndrome is Wernicke's speech problem, that is receptive aphasia. So hiran parietal එකේ චුට්ටක් එන්න පුළුවන්, but mainly temporal එකේ තමයි okay ප්‍රශ්නේ එන්නේ. Right. So that is an important problem. Also remember the temporal lobe is involved in your memory. It is involved also in your behavior as well. Hari behavior එකේ සම්බන්ධයකුත් තියෙනවා. Right. Okay. Fine. So what are the features would you expect in a patient with a lesion in the temporal lobe? So grasp reflex is a clearly motor function, right? And I told you that that is seen in a patient with a frontal lobe problem, right? Emergence of primitive reflexes are seen in a patient with a frontal lobe problem. Astereognosis, as we just discussed, is a clearly a sensory problem, right? So that is parietal lobe. Impaired memory, yes. Disinhibited behavior, yes, because remember the temporal lobe also is involved in maintaining some of your behaviors, right, and managing some of your behaviors, and problems with temporal can cause various unusual behavioral manifestations, right. Dysphasia, so this is again a receptive type dysphasia, mainly because it is the this is a Wernicke's area. Hari. Supunade memory impairment. Memory impairment is a bit complicated, right? Memory impairment is a bit complicated. You can get memory problems in the dominant or the non-dominant temporal lobe, but it's a bit of a complicated thing. Hari. එක පැත්තක් ගියා කියලා හැම වෙලේම වෙන්නෙත් නැහැ. සාමාන්‍යයෙන් දෙපැත්තම යන්න ඕනේ to have significant memory impairment. Hari. Okay. Right. Any questions about this one? So we're just going through the Katandari. Right? Okay, right. So you might get an MCQ on this. right? නිකන් ඔය වගේ ලයිස්තුවක් දෙන්න පුළුවන්. So it's important to know the clinical features of a damage to each of these lobes.
So the temporal lobe slide, that homonymous hemianopia clinica should be a quadrantenopia.
Oh, homonymous quadrantenopia, mean?
No. Sorry, parietal lobe slide.
Oh, ඒක quadrantenopia. Yes, that's right. Okay. Right. So cranial nerves. යන බලමු. Now the first MCQ is based on, so stereognosis දෙකේම එන්න පුළුවන්. Problems, it's all sensory. Sensory can go in either parietal lobe. There is no dominant, non-dominant for that. Right? So as I told you, in a parietal lobe, the sensory problems are uniform. Dominant giyat වෙනවා, non-dominant giyat වෙනවා. But special things like apraxias, Gerstmann syndrome or neglect, all of that is very specific to the dominant or non-dominant hemispheres. So frontal lobe lesion එකකත් memory problems එන්න පුළුවන්. Right? Especially memory වලට වැඩි, it's a concentration span sort of problem, right, that you get, right? And sort of a executive functioning, concentration වගේ දේවල්. ඔය serial 7 test කියලා එකක් කරන ඔය frontal lobe function, you might have heard of in psychiatry. So that is you හත අඩු කරනවා seeing. So those sort of concentration related tasks they cannot carry out. Right. Okay. So let's go to cranial nerve related MCQ. So first one is on papilledema. Now all of you have seen papilledema, right? And I have shown you these sort of slides before. Papilledema indicates the possibility of a space occupying lesion. Obviously, yes. That is on a babek එක ගහන්න පුළුවන්, right? So papilledema is a reflection of increased intracranial pressure and can indicate the possibility of a space occupying lesion. Right. Now, how does papilledema present? Now, papilledema per se doesn't cause a lot of clinical manifestations. Papilledema nisama enne naha. But of course, the patient might have early morning headache, right? Which shows that the patient has increased intracranial pressure. One of the probably only clinical features due to papilledema itself can be transient visual loss. We call this, the technical term is transient visual obscurations. Transient visual obscuration. A very sudden sort of loss of vision or alteration of vision. It's a very transient phenomenon. Very transient phenomenon. Right? So it doesn't present with progressive visual impairment. Right? Papilledema වල ඉන්නේ these transient visual obscurations. Right? So that is false, right? Now, papilledema, so as I told you, there are no specific clinical features of papilledema itself. Symptom එකක් නේ, only thing is this transient visual obscurations. Right. Now, in the fundus examination, one of the earliest things to be seen is loss of venous pulsation, right? That is the first, probably the first feature of papilledema, right? Loss of venous pulsation. The second feature is you get blurring of the medial optic disc border, right? So you get blurring of the medial border first, and then it involves the whole optic disc. With time, you can also get these hemorrhages around the optic disc, right? Or hemorrhages in the puluang around the optic disc. In very severe advanced cases, you can get around the optic disc these hemorrhages. Right? So the first thing you see is loss of venous pulsation, and then you see blurring of the medial margin of the disc, and then you see these hemorrhages popping up as the disease progresses. Right. So blurring of the optic disc margin is the earliest feature. කියන එක වැරදි. That is wrong. Right. Okay. Right. Next one. Papilledema is a recognized adverse effect of tetracycline. Now, this is something from your old pharmacology note. So, tetracycline, and another famous one is vitamin A, right? Especially when taken in a higher dose, right? Vitamin A, these can cause intracranial hypertension, right? or increased intracranial pressure as a side effect, right? So that is true. Right. Now, how would you investigate a person with papilledema? The first and most important thing to do is to do a comprehensive brain imaging, right? And I would say we need to do an MRI, right? Because you are looking for a structural lesion, right? CT scan make a muddy. To be absolutely certain, do an MRI scan. Also remember that with the MRI, we often do an MRV. MRI එකත් එක්ක අපි MRV එකකුත් කරනවා. And that is because this venous sinus thrombosis can cause papilledema. And it is often missed, right? Venous sinus thrombosis. If you don't specifically do an MRV or a CT venogram, you will miss venous sinus thrombosis. So, imaging is very, very important in the first instance. Imaging is very, very important. Right? That's the first thing that you do. Right? If your imaging is perfectly normal, right? So imaging includes you are looking at the structure of the brain, you are looking at the venous sinuses to see if there is evidence of venous sinus thrombosis. If everything is clear, there is no structural lesion in the brain, right? And there is no venous sinus thrombosis, all the imaging is normal, then it is very likely that this papilledema can be due to something called idiopathic intracranial hypertension. And that is diagnosed as a diagnosis of exclusion. MRI එක කරලා එක normal වෙන්න ඕනේ, MRV එක normal වෙන්න ඕනේ. And then you confirm that with an LP and you measure the CSF pressure, right? So that is right. Okay. So LP should be performed. Imaging fails to demonstrate a mass. Oh, sorry. එතන පොඩි ප්‍රශ්නයක් තියෙනවා. Mass lesion කියන නිසා ඕක මෙමයි. ඒක නම් මෙමයි. At an undergraduate level, ඕක හරි ගත්තත් වැරදි ගත්තත් I would give marks. But specifically when it says mass lesion, it is not talking about venous sinus thrombosis. You have to exclude a mass lesion and exclude venous sinus thrombosis before an LP, right? So රෝක හරි හෝ වැරදි දෙකම කමක් නැහැ, but remember them උගන්නපු එක මතක තියාගන්න, right? So LP එකක් කරන්න නම් ඉස්සෙල්ලා you should exclude a mass lesion with imaging and also venous sinus thrombosis. Both of these things can cause papilledema, increased intracranial pressure. හරි? හැබැයි undergraduate level එකේ අපි වැඩි venous sinus thrombosis ගැන කතා කරන්නේ නැහැ. ඒ නිසා කමක් නැහැ. හරි? කමක් නැහැ. Right. Okay. Right. Hiran, the word papilledema specifically indicates the presence of increased ICP. Right? Specifically. Now, for example, මේ වගේ වෙලාවට. Right? මේ වගේ වෙලාවට say for example, hypertension. Hypertension, you get disc edema, right? In very severe hypertension, you get disc edema, right? But that is, we don't call that papilledema. But it is not due to increased intracranial pressure. So the word papilledema is specifically used disc edema due to increased intracranial pressure, right? If it's just disc edema, you just call it disc edema. You don't call it papilledema. Right, so that's a very specific term for increased intracranial pressure related disc swelling. Right. Right. So Hansel, the point that you are making is that I told you that now neuroscience is not very keen on splitting these things up, functions up into dominant, non-dominant, because there's a lot of plasticity and people have lots of individual variations. So what you're saying is true. I don't want to bring that up because it's a slightly complicated area. It's not only in brain, lots of other parts of biology. People are now recognizing that there is no clear, strict compartmentalization of function, right? So that is a new trend that people are now going towards. Hari. Okay, fine. Hari, make a Hari. Make a MCQ. Right. Okay. So that's about papilledema. Any questions about that one? No, amaurosis fugax is not the same as transient visual obscuration. Amaurosis fugax, you get a very specific sort of syndrome where they have this sort of curtain falling like thing and going up again, right? But it is a differential diagnosis, right? You get transient visual loss. And one of the important things to look for when you have transient visual loss is to look at the fundus for papilledema, right? But it's not the same thing. Amaurosis fulgaris into a vascular problem, as you know. Right. Okay. Right. Now the question number 5 statement tonight, but visual field defects. Now this we have already discussed in absolute detail during your professorial appointments. So let's just quickly go through this MCQ. A lesion causing compression of the optic chiasm causes bitemporal hemianopia. That is true. So that's there, right? So in the optic chiasm, you get bitemporal hemianopia, right? And the reason is because the nasal fibers of the retina, which actually take light from the temporal fields, right, cross in the midline. Right? So that is why you get bitemporal hemianopia. Right. Then I talked about this homonymous quadrantanopia business. So I'm just going to tell that again, right? So this is the optic radiation. The optic radiation is split up into 2 bundles, right? Like this, right? You can see that very nicely in this picture, right? So this part, oops, sorry, right? So that part travels through the parietal lobe and this part travels through the temporal lobe. So optic radiation has 2 fibers. There is one set of fiber bundles that travel through the parietal lobe and the other set travels through the temporal lobe. Right. Okay. And the important thing to remember, light yanne anit pattata, right? So in the temporal lobe optic radiation fibers, they carry light from the upper parts of the visual field. The parietal lobe fibers carry light from the lower part of the visual fields. So damage the temporal lobe can result in homonymous superior quadrantanopia. Right? So temporal fibers will carry light from the upper parts of the visual field. Right. Okay. Now in your clinical appointments, I also told you about occipital lobe lesions. Now let's just revise that point. So when you get an infarct of the occipital lobe, you will get homonymous hemianopia. Why? Optic radiation fibers converge into the occipital lobe. They end up in the occipital lobe. So lesion in the occipital lobe, which is commonly an infarct, causes homonymous hemianopia. Right. Okay. Then in your appointments, I also talked about this concept of macular sparing. Macular sparing. Right. So say there is an infarct of the occipital lobe. Right. If there is an infarct of the occipital lobe. Right. If there is an infarct of the occipital lobe, the macular region is spared. What is the reason for that? Right. So the occipital lobe is supplied by the posterior cerebral artery. Posterior cerebral artery occipital lobe. Right. But the part that represents the macula is supplied by the middle cerebral artery. Right. So the part that supplies the macula is supplied by the middle cerebral artery. So in a pure occipital lobe infarct, which is posterior cerebral artery, the macula is spared. Well, that is supplied by something else, right? A middle cerebral artery fiber. But say you have a tumor in the occipital lobe that doesn't have any vascular territory. So it just invades everywhere. So if there's a tumor in the occipital lobe, that the macula is also involved. Right? So that is the importance of macular sparing in an occipital lobe lesion. So infarct of the occipital lobe causes complete homonym එක බොරු කතාවක් නේද? Because infarct is posterior cerebral artery, macula is middle cerebral artery. So the macula is spared if it is a occipital lobe infarct. Right. Rehan, you can get upper and lower bitemporal hemianopia, but that's a bit too complicated. Don't worry about that for the final exam. Right. හරි මම notes ටිකකුත් මේවයි දාලා තියෙනවා මේවාර පොතේ තියෙනවා and just to revise things. Yeah. හරි. Okay, so that is all about optic nerve disease. So optopapillary and visual field defects. Right. Any questions? So ideally, you have to use this red hat pin to sort of identify the macular or test the macular region, right? Okay, vibhagadi samanyen karanne naha, but if you get a patient with the homonymous hemianopia, you can say that I want to examine the macula with the red hat pin for macular sparing කියලා කිව්ව ගමන් කරන්න කියන්නේ ලකුණු ටික දෙනවා because now we know that we have understood that concept කියන එක. හරි? Yeah, so tumors can involve both hemispheres, that's true. But here, if it's a say, එක පැත්තක උනත් occipital lobe tumor එකක්, you get a complete homonymous hemianopia, right? But it can involve both hemispheres sometimes. So complete homonymous hemianopia කියන්නේ සාමාන්‍ය macula එක involve වුණාම තමයි. හරි? මම වැඩි හොඳට තමයි involvement of the macula කියලා ආයි දීලා තියෙන්නේ, but when you say complete homonymous hemianopia, that usually means that there is macula is gone. Okay. Now question number 5 is regarding the causes of bilateral ptosis. එතන මේකත් මම ඔයගොල්ලන්ට කියලා දුන්නා. Right? So remember, we talked about this. So ptosis is due to weakness of the levator palpebrae superioris. කළම ඔයගොල්ලන්ට මෙන්න මෙහෙම table එකක් so මේක පෙන්නන්නම්. මෙහෙම table එකක් පෙන්නන්න ඇති. Causes of bilateral ptosis and causes of unilateral ptosis කියලා. Right. Okay. Now, one of the important causes of bilateral ptosis is muscle disease, myopathies, right? And this is one famous myopathy here, right? It is called myotonia dystrophica, and I'm sure Professor Chang would have shown you a picture of that, right? This is called percussion myotonia. Right? You can see the sustained contraction when you tap the thenar eminence. Okay, so myopathies, and a good example is myotonia dystrophica, is an important cause of bilateral ptosis. Another important cause of bilateral ptosis are disorders of the neuromuscular junction, like myasthenia gravis, right? Or these things like these toxin-related neuromuscular junction disorders, right? So that is 2 we have discussed now, right? Third thing we need to discuss is, say you have a patient with a polyneuropathy. And the very classical example of this is Miller-Fisher syndrome variant of Guillain-Barré, right? So they again have a bilateral ptosis, right? And the other features of Miller-Fisher syndrome are the ptosis of ophthalmoplegia plus ataxia and areflexia. Right. So if you have a patient with bilateral ptosis, always think about these things. Could it be a myopathy? Could this be myasthenia gravis or other neuromuscular junction related toxin syndromes? Or could this be a Miller-Fisher syndrome variant of Guillain-Barré? Right. There is another unusual cause of bilateral ptosis which I will explain in a minute. True or false regarding the causes of bilateral ptosis? Miller-Fisher syndrome is true. Myasthenia gravis is true, right? Usually not. In a very common, usually not. Ataxia you don't get a full-blown cerebellar syndrome in Miller-Fisher. Right. Right. So Miller-Fisher syndrome, myasthenia gravis, Hari. Hump nose swiper වලට එන්නේ නැහැ. Neurological manifestations. Ecom aneurysm is unilateral third nerve palsy නේද? ඒක වැරදි. දැන් මේක ගැන මම වචනයක් කියලා දෙන්නම්. Right. Now, unusual cause of bilateral ptosis is a nuclear lesion of the third cranial nerve. දැන් මෙතන මේක ගොඩාක් complicate කරගන්න යන අවශ්‍යතාවයක් නැහැ. But in this picture, you can see I have shown you how the nuclear complex is organized, right, in the midbrain. So this is how the third nerve nuclear complex is organized in the midbrain, right? So you can see there is a individual muscle innervation whenever there are small parts of the nucleus for individual muscles. What is important is there is only one nucleus for the levator palpebrae superioris. That is the important feature, right? There is only one nucleus for the levator palpebrae superioris. So even if there is a unilateral lesion here, right, you will still get bilateral ptosis, right? So that is why if there is a nuclear lesion of the third nerve in the midbrain, you can get bilateral ptosis because it is just there is only one levator palpebrae superioris nucleus. Whereas all the other ones there are two, one for either side. Okay. And there is some other important messy thing that happens here, but that is too much for you for the moment. Hari. Yes, Tisura.
So according to this superior rectus is crossing.
ඒක තමයි ඔයගොල්ලෝ දැම්ම වැදගත් නැති තව අමුතු දෙයක් වෙනවා කියලා කිව්වේ, right? So because you have now asked the question, another unusual thing is that the superior rectus nucleus එක පැත්තක තියෙන එක අනිත් පැත්තට තමයි දෙන්නේ. That's a rather unusual little business there, right? So you can see this superior rectus nucleus here. It gives a fiber through the midline to the other side, right? මේ පැත්තෙන් ඔහොම යනවා. Okay. So that's another unusual thing, which if you can think of causes another interesting manifestation, right? So එක පැත්තක nucleus complex එක ගියාම you get bilateral ptosis, and also something interesting happens to the superior rectus. You can work it out, but I'm not going to mention it because it's a postgraduate thing. Right? But you can work it out if you like. So lesion of the nuclear complex of the third cranial nerve can cause bilateral ptosis because of the fact that there is only one nucleus for the levator palpebrae superioris, as I have shown. Hari. හරිද බලන්න එක? Right. Now then we go on to third cranial nerve palsies. Okay, third cranial nerve palsy. හරි, දැන් මේකේ ගොඩාක් ඒවා අපි ක්ලිනිකල් වලදී කතා කරා. Let's go through these answers now. Third cranial nerve palsy is the commonest cranial nerve palsy in raised increased intracranial pressure. ඒක වැරදි. It's the sixth nerve. It is not the third nerve. Right. Of course, the third nerve can get affected when there is coning. Right. But that is the end stages. Right. What you first see is because of the increased intracranial pressure, you get this sixth nerve palsy. Right. But when the patient is coning, you can get a third nerve palsy. Right. But that's not very common. Right. Now, third cranial nerve palsy can be caused by an aneurysm of the anterior communicating artery, posterior communicating artery. මතකයි නේද කතන්දරේ? So remember we talked about this. The third cranial nerve, as it exits the midbrain, lies close to the posterior communicating artery. Right? Remember we talked about this. Oops, sorry. Posterior communicating artery. So not the anterior communicating artery. ඒක වැරදි. Right. Okay. Now, the third nerve, apart from its motor function, right, also has a series of parasympathetic fibers that go on the outermost aspect of the third nerve. right? So your parasympathetic fibers go on the outermost aspect of the third cranial nerve, right? If there is a third cranial nerve palsy, you can get a pupillary dilatation, right? Pupillary dilatation, right? But the optic nerve is okay, right? So the other side, the consensual reflex is okay. The pupil is constricting on the other side. There is no problem there, right? But on the side there, the third nerve is affected, you can get pupillary dilatation and absent light reflex. Okay. Right. Okay. Now, so in a third nerve palsy, what are the features you would get, right? You get ptosis and sort of a lateral deviation of the eyeball, lateral and downward deviation of the eyeball, right? This is because the lateral rectus and superior oblique muscles are spared. We remember this story. So affected eye has a convergent squint, divergent squint, because the lateral rectus is pulling the eyeball. Hari. Okay. Right. Fine. Right. Hari. Now, we talked about, when we were doing your clinical appointments, we talked about the course of the third nerve and lesions along the course of the third nerve. So I told you that the third nerve can be affected in the midbrain, right? And that can cause a third nerve palsy, right? Now I have given you some additional information about that as well, right? Midbrain nuclear complex third nerve palsy right? But we also know that in the midbrain, when the third nerve is damaged, there can be other structures which are affected, right? One classical example is you get Weber syndrome. Weber syndrome, you get problems of the motor pathways, right? The corticospinal tracts are affected in the midbrain. So because of that, you get contralateral hemiparesis. The contralateral hemiparesis, because the pathway hasn't crossed, right? You get contralateral hemiparesis, right? So that is a midbrain lesion. Another interesting thing that happens in the midbrain is this, right? But the third nerve goes very close to something called the red nucleus, and you get this very gross sort of tremor called a rubral tremor. Right? So rubral tremor. Right. Right. It looks like a cerebellar tremor, but it's not. It is a more large volume. You can see that very large volume. Right. Okay. So midbrain lesion contralateral hemiparesis, and rarely you can get this rubral tremor, again, which is contralateral or bilateral. Another problem you can get in a midbrain lesion is it can cause cerebellar signs, right? But because the cerebellum is connected to the same side, midbrain, it will be always an ipsilateral thing, right? Ipsilateral thing. Hari. Not very important. Hari. So lesion in the midbrain can present with third nerve palsy and ipsilateral hemiparesis contralateral hemiparesis vendone. This is because the corticospinal tract has not crossed yet. Hari. Right. Somebody else? So stem. Oh, so affected eye convergent can lateral rectus it goes, it's a divergent squint that you get, Prasad. Right. Now when the third nerve comes out of the midbrain, it lies close to the posterior communicating artery, and then it goes through this series of structures like the cavernous sinus, superior orbital fissure and orbital apex. So a lesion in the superior orbital fissure, what will happen? In the superior orbital fissure, what are the structures? 3, 4, 6 and 5 ophthalmic vitarai yanne neda. So this is wrong because in the superior orbital fissure, the third nerve ophthalmic division is affected and not the maxillary division, right? In the cavernous sinus, both divisions are there, but as it goes into the superior orbital fissure, it is only the ophthalmic division that is present, right? So that is important, right? Okay. Now, in your short case discussions, I also talked about what are the causes of isolated third nerve palsy. So if there's an isolated third nerve palsy, an important thing you need to consider is that, is this a medical cause like diabetes or vasculitis, right? Or is it a compressive cause at the posterior semi-indicating artery level, right? And I told you it's very easy because you know the anatomy of the third nerve. The parasympathetic fibers are on the outermost aspects. So anything causing a compression of the third nerve will cause pupillary dilatation. Eh? That will cause pupillary dilatation, compression. Right? Whereas something like diabetes or vasculitis does not cause pupillary involvement. So vasculitis can cause ptosis with spared pupils. That is true. So vasculitis can cause a third nerve palsy, but the pupil will be spared. Fine. So that is an MCQ on third cranial nerve palsy. Any questions? Hari Prasad, sorry, ma hatara kiwe mekane, so man kiwa uttare. It can cause a third nerve palsy with sparing of the pupils. Right. Okay. So this is just a revision of the third cranial nerve. I didn't go into depth about it, but just we are revising some of these concepts. Sorry. Make a notes if you are interested. May presentation make short cases appointment right. Now the fourth cranial nerve is not a very common cranial nerve palsy, right? So we don't talk about it too much. The classical presentation is when you look downwards, there is vertical diplopia. Right. Now let's talk about the lesions of the sixth cranial nerve now. Now, sixth cranial nerve is a very important cranial nerve for your short cases as well. Right. So what happens when you have a lesion of the sixth cranial nerve? You get a convergent squint. A convergent squint. Because the lateral rectus is weak. And the diplopia has to be horizontal diplopia. Right? It has to be horizontal diplopia, not vertical diplopia. Right? Because the lateral rectus moves the eyeball horizontally. So there will be horizontal diplopia. Right. And remember, this horizontal diplopia is binocular. Right? Binocular. එකහැක් වැහුවොත් එහෙම diplopia එක තියෙන්න විදියක් නැහැ. Right? එකහැක් වැහුවොත් diplopia එක තියෙන්න විදියක් නැහැ. The whole problem is the two eyes are pointing in two directions. So you get diplopia, and this is binocular diplopia. Right? Binocular diplopia. So එකහැක් වැහුවම diplopia එක නැති වෙන්න ඕනේ. So diplopia persists on closing the affected eye. That is absolute rubbish. එහෙම වෙන්නේ නැහැ. Right? Remember, in cranial nerve palsies, the diplopia you get is because the eyes are pointing in different directions. Right? So, it always has to be binocular. The cranial nerve palsy related diplopia is binocular. Binocular. Right. Where uniocular diplopia and say problem with the lens or ඇතුලේ මොන හරි ප්‍රශ්නයක් තියෙනවා. ඒක ඇහැ ඇතුලේ ප්‍රශ්නයකදී, and those are ophthalmology stuff. Don't worry about that. Right. Right. Now, again, when we are talking about the sixth nerve course, I told you that the sixth nerve starts in the pons, right? And then moves anteriorly towards the cavernous sinus, right? And a very important cause of isolated sixth nerve palsy would be increased intracranial pressure, right? commonly associated with increased intracranial pressure. Another important cause of isolated sixth nerve palsy would be diabetes or vasculitis, right? A mononeuropathy, right? And I told you at the exam, when you're looking for these things, sorry. When you're looking for these, look at the fundus, look for papilledema, right? That is an important thing. If you get a sixth nerve palsy patient for the exam, please look at the fundus to look for papilledema. Right. Sixth cranial nerve is never involved in CP angle tumors, right? Except in the rare instance that the tumor is so massive, it causes increased intracranial pressure. These tumors are not very big, right? So, CP angle ekata sixth nerve එක යන්නේ නැහැ. That is very important. So, don't make a mistake. The sixth nerve moves anteriorly, whereas the seventh nerve moves laterally into the CP angle. So, you cannot have a CP angle tumor causing a sixth nerve palsy, and it is massive, causing increased intracranial pressure. So, it's affected early in patients with CP angle tumor. Boru katawa. It's wrong. Harine? Okay. So in the next few slides, again, I have given you some notes if you want to read and revise about these things. I have talked about all of these in your short cases, right? At the pons, remember we talked about the facial nerve being close to the sixth nerve, right? And then we have talked about the whole course into the cavernous sinus, superior orbital fissure, heavily hill and ava. Right. Any questions about that one? Okay, right. Then so I just want to show you something. MCQ when I was looking at your old papers. So I just want to tell you a few words about this. So in eye movement control, an important concept is conjugate eye movements. Conjugate eye movements are, right, when you're looking at something, there needs to be coordination between all these cranial nerves, right? Tuna, hatara, higher, all these cranial nerves need to work in coordination when you're looking at an object. And the mechanisms that control that are called conjugate centers, or there are certain areas in the brain stem that are called conjugate gaze centers. Conjugate gaze centers. Right. Now, the two most important conjugate gaze centers are located in the pons, right? And the biggest one is called the PPRF, parapontine reticular formation. And there is another connecting bundle of fibers that connect all the nuclei together, and that is called the medial longitudinal fasciculus. Medial longitudinal fasciculus. So these two, the parapontine reticular formation, which is in the pons, is a very important center. And there is also this connecting bundle of fibers that travel up and down the brainstem, which is called the medial longitudinal fasciculus. These two structures are extremely important for conjugate case when you're looking at something, to coordinate all the eye-related cranial nerves and muscles. Right? And when you have a problem in these conjugate gaze centers, right, you get things like this, which is called internuclear ophthalmoplegia. නිකන් බලන්න මේකනේ ආසාවට. Right? මේ විභාගෙට දෙන්නේ MCQ වලට සමහරලාට අහලා තියෙනවා. Okay, so there are problems in coordinating the eye movements. May patient gas individually බැලුවොත් එහෙම ප්‍රශ්නයක් නැහැ. Right? Individually, all the if you close one eye and just examine each eye separately, yeah, they are working. Right. Okay. So parapontine reticular formation and medial longitudinal fasciculus are two important conjugate gaze centers, and they mainly control the horizontal conjugate gaze කියලා මතක තියාගන්න. So, Gary, third cranial nerve palsy, diplopia is obviously, actually, third cranial nerve palsy doesn't present with diplopia because it automatically වැහිලානේ තියෙන්නේ. So, ඒක ඇරියාම තමයි diplopia එක පේන්නේ. ඒතර ආයි වහන්න ඇරලා කරන්න දෙයක් නැහැ because of the ptosis. That's actually a good thing sometimes because the ptosis it prevents the patient from having diplopia because ඉබේටම එක හැක් වැහිලා තියෙන්නේ. ඇරිය ගමන් diplopia එනවා. ඒතර ආයු කහ ඇරලා වහන්න දෙයක් නැහැ. හරි? නිකන් අහන්න පුළුවන් නිකන් resting position එකේ do you have double vision කියලා අහන්න පුළුවන්. Right? That's one eye is automatically closed. Right. Now question number 8 focuses on seventh nerve palsy ළමයි. Right? Seventh nerve palsy. Now seventh nerve palsy ගැන අපි කලින් කතා කරලා තියෙනවා. Again this will be a revision for you. Right. Now seventh nerve palsy, as you know, we describe as upper motor neuron seventh nerve palsy and lower motor neuron seventh nerve palsy. Right, upper motor neuron and lower motor neuron. Right. The first MCQ is upper motor neuron type facial nerve palsy presents with predominant weakness of the upper part of the face. Now make a matakai neda. You remember this story where if you take the facial nucleus in the pons, right, it has a very nice organization, right? The facial nerve nucleus in the pons has an upper part and a lower part. The upper part, right, supplies the upper part of the face. Easy. The lower part of the nucleus supplies the lower part of the face. So it has an organization within that nucleus, right? Upper part of the nucleus supplies the upper part of the face. Lower part of the nucleus supplies the lower part of the face. Nicely organized, beautifully organized nucleus. Right. Okay. Now, ඊටත් වැඩිය වැදගත් වෙන්නේ the upper part of the nucleus gets upper motor neurons from both cerebral hemispheres. The upper part of the nucleus gets fibers from both sides. Whereas the lower part of the nucleus only gets fibers from the opposite side. Right? That is the reason. Because if you have upper motor neuron facial nerve palsy, the upper part of the face is not affected because it has a dual innervation, right? It has a dual innervation from both cerebral hemispheres. Okay. So upper motor neuron facial nerve palsy, well, upper part of the face is intact because it has from both sides you get innervation. There is a very rare situation where you can get bilateral upper motor neuron involvement. That is very, very rare. හරි ඒකේ අමුතු සෙල්ලමක් වෙනවා ඒක ඔයගොල්ලෝ කලබල වෙන්න දෙයක් නෑ at this stage. Right. So upper part yeah, so make a balance. Right. Okay. Now another famous area for MCQ is what are the causes of bilateral facial nerve palsy? Bilateral facial nerve palsy. Right. So bilateral facial nerve palsy වලට සාමාන්‍යයෙන් nerves දෙකම දෙපැත්තේ nerves දෙකම affect වෙනවා. There are some conditions that cause it. Right. ලයිස්තුවක් තියෙනවා. Right. One of these is sarcoidosis. Another one is Lyme's disease, right? Sarcoidosis, Lyme's disease, right? TB වලත් සමහරලාට එනවා TB වල, right? තුනයි. Like TB, another mycobacterial infection, leprosy we have seen bilateral facial nerve palsy, හතරයි. And the other one is there are variants of Guillain-Barré syndrome or Guillain-Barré itself can sometimes involve the facial nerve bilaterally. Guillain-Barré or variants can involve the facial nerve bilaterally. Okay. So these are all the causes of bilateral facial nerve palsy. Sarcoidosis, TB, mycobacterial leprosy, Lyme's disease, and also this Guillain-Barré or variants of Guillain-Barré. Right. Now again, like the sixth nerve, during your clinical appointments, we talked about how the facial nerve travels through the skull and then outside the skull. Right. So the facial nerve starts in the pons and very close to the sixth nerve nucleus and then enters the cerebellopontine angle. And from that point, it travels inside the petrous temporal bone, which is this big area here. Right. So let's do the MCQs. Now, herpes zoster affecting the geniculate ganglion causes Bell's palsy in a way that is called Ramsay-Hunt syndrome. Ramsay-Hunt syndrome. So inside the petrous temporal bone, there is a very important structure which is called the geniculate ganglion. And you can get herpes zoster involving the geniculate ganglion, giving rise to Ramsay-Hunt syndrome. Ramsay-Hunt syndrome. Right. Okay. Due to lesions in the pons can have associated horizontal gaze palsy is true. So remember in the pons, the pons is where the facial nerve starts, and in close location to the facial nerve, you have the sixth nerve nucleus. Right. And also, that this horizontal gaze control centers, the parapontine reticular formation is also in the pons. So you can get these either a sixth nerve palsy or a horizontal gaze palsy when you have a seventh nerve palsy, because it is all in the same sort of location. Right. Final MCQ. Seventh nerve palsy exits the pons and goes into the CP angle. In the CP angle, right, you have the fifth nerve and the eighth nerve in very close proximity. But it is not the seventh nerve that is affected first in a tumor of the CP angle, it is the fifth nerve. So, mulimma fifth nerve. So, pahata tunak tibunata. The first cranial nerve that is affected is the fifth nerve always, right? And actually, in the fifth nerve, it is the corneal reflex that is affected first. Corneal reflex katamai issalama affects venne. So, is the earliest sign of a tumor nevei eka varan. Any questions? Okay. This is a picture of Ramsay-Hunt syndrome. Okay. Right. Now, Bell's palsy. Look at this. Look at listen. Yeah, so you can say that, yes. So when you can't localize it exactly, you can say it's possibly Bell's palsy. If you like, right? Hi. True or false regarding Bell's palsy? Then a balloon put up Bell's palsy again. Right. Tappara then, Hi. Okay, sorry. No. So in CP angle tumors, it is the fifth nerve that is affected first, and specifically the corneal reflex that is affected first. Right. Okay.
So do all the other cranial nerves have this dual innervation from both hemispheres? So this dual innervation from both hemispheres?
You mean the upper motor neuron innervation, right?
Yes, exactly. That
yeah. So upper motor neuron, most cranial nerve nuclei have bilateral innervations, upper motor neuron innervation. There are few exceptions. Right? There are exceptions. Right? But those are a bit niche. Right?
Right.
For example, tongue එක genioglossus කියලා මස්සල එකක් තියෙනවා. ඒක එක පැත්තකින් විතරයි එන්නේ. Right? Also certain upper oculomotor nerves වලත් සමහර nuclei වලට there is only a unilateral innervation. So there are some funny things like that which are not very important, at least at this stage. Right. Clinically වැදගත් එක තමයි facial nerve, because that's why we teach that to you. Right. So true or false regarding Bell's palsy, commonly due to viral etiology. Yes, that's true. What virus කියලා අඳුරගන්න අමාරුයි, but it is often viral. Yes. Patients with diabetes and pregnancy, they have an increased risk, not a decreased risk. There is an increased risk, right? And Bell's palsy is probably the commonest cause of facial nerve palsy. I think all cases, 70 to 80% are due to Bell's palsy. Now, Bell's palsy has a spontaneous improvement in most people, right? But some, I think the values, but please check me on this, 15 to 30% විතර තමයි the studies range show a residual long-term weakness, right? So 15 to 30% විතර they have a residual weakness, right? Residual weakness. 15 to 30% තමයි hari. Now, how do you treat Bell's palsy? Steroids, right? And acyclovir are commonly used, right? In this treatment. Now, actually, steroids, if given early, right, say within the first 72 hours, has an effect on disease progression. But you have to give it early on in the disease course. සාමාන්‍යයෙන් පැය 72කට පස්සේ දීලා වැඩක් නැහැ, right? So in the early stages of the disease, say within 72 hours, there is a benefit and it reduces the progression of the disease, right? Acyclovir is used, right? But it is not recommended, right? It is not recommended. අපි සාමාන්‍ය acyclovir දෙනවා, and there is no evidence really that it does have any benefit. Benefit එකක් තියෙනවා කියලා nobody has really described in the literature. So is recommended this false, we give it, but none of the guidelines recommend it and there is no clear outcome. If it is Ramsay-Hunt syndrome, yes, there is no doubt that it has a benefit, right? And it is recommended. But yeah. අපි Bell's වලත් ඔයගොල්ලෝ දැකලා ඇති අපි acyclovir දෙනවා ගොඩක් අයට, but who knows whether it has any benefit, right? Steroids, yes, if you give it early, there is a good prognostic outcome with early steroid treatment. Sorry. Any questions?
So that first statement, commonly due to viral etiology, is made by definition since it's idiopathic, can we say?
Hey, මුලින්ම describe කරනකොට idiopathic, but now we understand that it's mostly viral in origin. So some of the textbooks say idiopathic, but that is sort of, we know that it's mostly due to viruses. What virus is difficult to say. Right?
Right, okay.
Right. Now, the last few questions are on brainstem, lower brainstem syndromes. Right? Now, I told you that we often refer to the collection of 9, 10, 11, 12 and a part of the fifth cranial nerve as bulbar cranial nerves. So that collection of cranial nerves, 9, 10, 11, 12 and part of the fifth nerve are bulbar cranial nerves. So a disorder of these cranial nerves together, right, when the lower motor neuron pathways are involved, is called bulbar palsy. And when the upper motor neurons are involved, is called pseudobulbar palsy. Right. So this MCQ is asking you for the features of pseudobulbar palsy. Right. Dysphagia එනවා. Positive jaw jerk එකකුත් එනවා. But and emotional lability, these are all features of pseudobulbar palsy. Right. The positive jaw jerk is because of it, that is because it is an upper motor neuron syndrome. Right. Fasciculation, wasting of the tongue muscles, that is bulbar palsy, because that is a lower motor neuron manifestation. Dementia එන්නේ නැහැ. Right. Dementia is not related. Does not occur in pseudobulbar palsy per se. Right. Right. So these are the syndromes of bulbar palsy and pseudobulbar palsy. Any questions about this? Right. another very important neurological syndrome that occurs in the medullary region is lateral medullary syndrome, right? Okay, and this is a very famous syndrome that so Rehani, there can be an association with other dementia syndromes. Say, for example, as you say, something like frontotemporal dementia, but සමහරවිට pseudobulbar palsy එන්න පුළුවන්. Because these disease processes can cause degeneration of the upper motor neurons, right? Some of these dementia syndromes can ultimately cause degeneration of they're all neurodegenerative, so they can be associated with degeneration of the upper motor neurons, giving rise to things like pseudobulbar palsy also. But pseudobulbar palsy කියන වචනේ ඇතුලේ dementia කියලා එකක් නැහැ. Right. Okay. So usually pseudobulbar palsy is due to bilateral involvement. ඒක එක පැත්තක් කියන එක බොහොම කලාතුරකින් usually you get bilateral involvement, right? Pseudobulbar is most often due to bilateral upper motor neuron involvement, right? Okay, so lateral medullary syndrome, right, is due to the occlusion of the pica, right? So that is the posterior inferior cerebellar artery, right? Not the posterior communicating artery, right? And you're very familiar with this picture where you see the lateral part of the medulla being involved. An important general principle is lateral medullary syndrome does not involve the pyramidal tract. So the pyramidal tract travels anteriorly. It does not cause hemiparesis. That is an important principle to remember. Right. And because the lateral part of the medulla is involved, you get interruption of the sympathetic pathways causing ipsilateral Horner syndrome, cerebellar vestibular connections which cause ipsilateral vestibular and cerebellar signs. Ipsilateral, remember cerebellum is always ipsilateral. And you get this very typical checkerboard sensory loss. Neither checkerboard sensory loss කියන්නේ same side of the face affected but opposite side of the body affected. That's called a checkerboard sensory loss. මූණේ මේ පැත්ත නම් ඇඟේ අනිත් පැත්ත. That's called a checkerboard sensory loss. That is also seen in lateral medullary syndrome because you have the sensory pathways in the lateral part of the medulla. Right. Okay. Right. So this table I've shown you before, it just gives you the comparison between bulbar and pseudobulbar palsy. Right. Okay. Right. So that is that for the day. So we've just gone through the cranial nerves and the sort of the higher function, disorders of higher cerebral function. Any questions? Right. So Nipun Haltino, in a patient with homonymous hemianopia, what are the features we should look for? Differential optic tract. So Nipun, that's a complicated thing. It's very difficult to differentiate clinically, right? So as I have told you before, any lesion distal to the optic chiasma can give rise to homonymous hemianopia. So that can be the optic tract, the radiation, or the occipital cortex. Differentiating these three clinically is very, very difficult and needs usually a mapping out of the visual fields and certain ophthalmological investigations. Clinically, tika kamaru yoga karan. Alright, so don't worry about that. So checkerboard කියන්නේ sensory loss එකන්නේ ipsilateral face, contralateral body because the sensory spinothalamic tracts have not crossed it. So it causes sensory loss on the opposite side of the body. But the trigeminal nerve nucleus is in the lateral part of the medulla which causes the sensory loss on the ipsilateral face.
Excuse me, sir.
Yes, Kevin.
Frontal lobe එක ගියාම can we get any visual palsies?
Frontal eye field effect. That is a different. That is a very different thing. A frontal eye field is mostly involved in motor coordination, not visual fields.
Right. So අර characteristic එක මොකුත් වෙන්නේ නැහැ නේද?
ඒ වගේ වෙන්නේ you get eye movement and some unusual eye movement disorders when you get the frontal lobe involved, but those are very complicated.
Thank you.
sir මේ
Oh, sir.
ස්මෙල් එක යන්නේ මොන ලෝබ් එකෙන්ද?
That is a very complicated thing. So the olfactory pathways are very complicated because they go ultimately into the temporal lobe. Part of it is in the parietal lobe. There are lots of bilateral connections, and purely because of a temporal lobe lesion, එක පැත්තක ගියා කියලා smell එක යන්නේ නැහැ. And there are lots of connections between the smell centers in the temporal lobe and the parietal lobe. ලොකු interconnections ගොඩකුත් තියෙනවා. Right?
Okay.
Right. So, Vishwa, it is very difficult to check for the fourth cranial nerve clinically. එකටත් අර ඕනේ මේ ophthalmological test එකක් තියෙනවා where you can assess the eye movements. It's very difficult to do that clinically. It's a very subtle change එකක් තමයි එන්නේ ඒකේ. හරි. පොඩ්ඩක් අර පල්ලෙහා බලනකොට පොඩ්ඩක් eye movement එක පැත්තක අඩුයි කියලා වගේ පේනවා, but it's very very difficult to do. හරි. There is also another thing you can check for, which is called intorsion. ඒකත් ටිකක් complicated mechanism එකක් ඒ ඔයගොල්ලෝගෙන් අහන්නේ undergraduate level එකේ. හරි. එතකොට සමහරවිට හෙට එතකොට හෙට වෙලාව මේ වෙලාවටම වගේ පුළුවන් නේද?
පුළුවන් සවුලක් නැහැ.
හරි. එතකොට ඒකේ තව ඉතුරු ටික කරන්න පුළුවන් එහෙනම් ඒක ඉවර කරලා දාමු. ඔව් ඒකේ සෙරිබෙලම් මනම් ওই ටික තමයි තියෙන්නේ මෝටර් ඒවා ටික. වැඩි වෙලා යන එකක් නෑ. ඒක කරලා ඊට පස්සේ ඔයගොල්ලන්ට අර ටික කරලා දාන්න. හිමටොලොජි එකයි රුමටොලොජි එකයි කරලා දාන්න. ඒකට ඒක සම්බන්ධ කරුවද කරලා ඉවර කරන්න පුළුවන්. හරි.
හරි.
හරි. Okay right. හරි එහෙනම්.
Thank you very much, sir.
Okay right.